Our speaker this evening is Dr. Anna Wilkinson, a family physician at the Ottawa Hospital with special interest in oncology. She's going to be talking about how PSA screening recommendations have impacted prostate cancer outcomes in Canada. She has just finished a study and it's been submitted for review. So while we have her presentation and we're taping the session, we will not make it available until the study has been approved.
Published. Which
Published.
would be hopefully in a week or two.
Okay, so it will be available eventually. So up on our website, but we have to wait. Okay. Welcome, Anna.
Thank you. Perfect. Yeah. So as you said, first of all, thank you for having me. Super excited to be here and translate some of this research into kind of the people that it matters to. So I'm a family doctor. I work teaching family doctors at the Ottawa Hospital, but I'm also a GP oncologist. So I work on the oncology wards part of my week, and I look after people who are admitted with cancer. So I see really all sides of these issues, and that's really prompted me to do research on cancer screening, which is where we're going to talk about today. So these are my disclosures. I want to highlight Prostate Cancer Foundation Canada, who helped me do this study and helped StatsCan do this study, and the Sullivan Urology Foundation grant that also helped fund this study. And Eric Dorff over there is from StatsCan. Why don't you introduce yourself?
So I'm Eric Dorff. I'm the chief of the Canadian Cancer Stats program that looks after the Canadian Cancer Registry with the provinces and territories. So we get all the data on individuals and tumors, and then we're able to link that up to our other data sets, including the census, and help researchers like Anna develop things like this.
So if you have any questions about any of those statistics, you can head them that way.
Sure.
So I probably don't have to tell you about prostate cancer. You are more than aware that it is super common. It's the most common cancer in Canadian men, aside from skin cancers. There's about 28,000 cases per year. It's the third leading cause of death in Canadian men from cancer, and it's 11% of all cancer deaths. Now, I come at prostate cancer from sort of a different view. So my work to this point has been a lot in the breast cancer area. And looking at breast cancer and looking at prostate cancer, I started to realize there were a lot of commonalities. So breast cancer, the numbers are very similar. There's about the same number of cases per year. It's, I think it's the second leading cause of death from cancer in women. But there's some major differences as well. So the biggest difference, I think, is for breast cancer, we hear all this media about catching it early, finding it early, screening. We have organized screening programs. Every single province has a screening program where you get called, you get letters, there's defined ages. And so people have been screening for breast cancer for decades. And yet for prostate cancer, there's no equivalent. It's just as common, but we don't screen. And so that was really the trigger for me saying, like, why don't we screen for, why are we not doing this if it's so similar? And you look in the media, and really a lot of the language around prostate cancer screening in the media is very negative. It's about overdiagnosis. This is, a disease of older men. But we know that prostate cancer, the average age of diagnosis is about 5 years older than breast cancer. So it's not that different in terms of the population. And so this is the question that sort of triggered me to go to StatsCan and say, hey, can we look at this? And Eric luckily said yes. So this is a little bit, I'm going to talk about breast cancer, which is probably not what you'd normally talk about here, just to get going. But this was the study that we did to look at the impact of breast cancer screening in women in their 40s. So the controversy for breast cancer, we know there's very established screening for women 50 to 74, but the 40s was always a question of should we be doing it or not? And so again, looking at this and seeing, like I see from my perspective, women admitted in the hospital who were in their 50s and 40s with breast cancer, we started to say, okay, we need to look at this. And so we did. But because we have provincial healthcare system in Canada, and because some provinces screen and some provinces don't screen, we said, you know what, we kind of like it or not, we've been running a natural experiment here. And we can use the geographical differences in screening programs to figure out what the impact is on breast cancer. And so that's what we did. And we found that the screeners are the blue. So provinces that had screening programs for women in their 40s had significantly earlier stage at diagnosis, and they had significantly improved survival. So then I started thinking, okay, well, prostate cancer, we don't have geographical differences, and we have somewhat in that PSA is funded in some provinces and not, but there's no organized screening programs for prostate cancer. But we do have one difference that we can look at to try and figure out what the impact of PSA screening has been. And that's a temporal difference. So we've seen changes in prostate cancer screening guidelines over time. And so whereas for breast, we were saying, okay, let's look at it based on geography. For prostate and PSA, it was, you know, we can look at this based on time and temporal changes and see what's been going on. So before we get into this study, I'm going to back up and just do a little bit of overview about cancer screening, because you have to understand cancer screening to understand some of the reasons why you might or might not want to screen. To me, cancer screening is common sense. Like you take your car in to get serviced, you change the oil, you do preventive maintenance. Cancer screening is the same thing. You're just taking care of your body. And really what you're doing is you're trying to find a problem before it starts, or when it's a very small problem so it doesn't become a big problem. And so when you think about cancer screening, typically you have these healthy cells that have a trajectory. They become more and more abnormal, they become eventually pre-invasive, then they become invasive, and then eventually spread. And so the theory about cancer screening is if you can find things here, then you can deal with them before they become invasive or before they spread. So the essence of screening is you do not have symptoms. This is a healthy population with no symptoms where you're doing a test to find an early stage cancer. If you have symptoms, that's diagnosis. And so for prostate cancer, those would typically be urinary symptoms or even bone symptoms if it's metastatic. And so when your diagnosis, you have enough size of the tumor and tumor growth that you're starting to experience things happening from that. And so you have things that prompt you into investigations. Whenever you're thinking about screening, you have to, for any medical test, you're thinking about benefits and harms. And obviously for a screening test to be something you advise, you have to find that those benefits outweigh the harms. You also have to really understand the test, because not every test is perfect. Every medical test has a plus or a minus. You know, your blood test that you go for, even your CT scan, that it's not black and white always. And so if you understand the limitations of the test, then you can adapt how you use those tests to make sure that you're getting the most benefit and the least harm. So let's talk about harms, because this is what comes up in prostate cancer a lot, and prostate cancer screening is that the focus is really on the harms. And so we have to understand what those harms are to see if we think those are really something that's outweighing those benefits. And so these are the harms we think about with screening: false positives, false negatives, and overdiagnosis. So a false positive is essentially when that, if we're talking about PSA testing, your PSA is increased, but it's not a cancer. And so you might see a PSA increase because you have an enlarged prostate with age or BPH. Sometimes even just if you've gone on a bike ride, that's enough to bump the PSA up enough. And so there is a risk with PSA screening that if that PSA is elevated, you might have a biopsy that you didn't need. False negatives are when the test doesn't pick up the cancer. This is something we see in breast, not uncommonly with mammograms in women with dense breast. You just can't see the cancers. In prostate cancer, this is less of an issue, but there are some prostate cancers that don't produce a lot of PSA, and so you might not pick them up. An overdiagnosis is the one that we hear over and over again in terms of prostate cancer and harms of screening. And so this is the one I think that's really important to understand. So overdiagnosis is the concept that you're going to diagnose a cancer that wouldn't have caused a problem in that person's life. And so you're going to expose them, you're going to find something, you're going to make them worry, you're going to make them go through all this stuff, and it never would have been an issue. And overdiagnosis is really, there's kind of two scenarios where this fits. So for overdiagnosis, so typically overdiagnosis would be an issue if you had competing medical issues. So if you have such a bad heart, you have a lot of heart disease, you're going to die of a heart attack next year. If we treat a prostate cancer now and put you through all this treatment that might save your life 10 years from now, that's an overdiagnosed cancer. I think we need somebody. The other time you get overdiagnosis is when the cancer is more indolent or slow growing and would kind of just grumble along and never really cause a problem. And with prostate cancer, that does exist. There are sort of those Gleason 6 or earlier, less aggressive prostate cancers. And so you have to be cognizant that finding those, what you have to tease out though is overdiagnosis and overtreatment. So overtreatment is treating something that wouldn't have caused a problem. So just because you diagnose something doesn't mean you have to treat it. So for maybe that Gleason 6, where you're less worried about it, if you follow it along, and this is where active surveillance comes in, then you can kind of jump in if and when it becomes a problem. So just because you find it, you don't have to actually treat it. Because if you do have treatment that isn't necessary, of course you're going to end up with side effects that you shouldn't necessarily have had. And I think one of the concepts that's really important to think about in prostate cancer screening is uncoupling that diagnosis from that treatment. So not everything you find, you have to treat. So those are the harms. My bias is certainly working in the oncology field that I think screening is pretty great. Anytime we can find something before it's a problem, it's a good thing. But there's evidence to support that. And so the benefits that we see are earlier stage at diagnosis, decreased morbidity, so less intense treatments, less aggressive treatments often, decreased mortality, and cost savings to our system. So again, we're going to go through these. So earlier diagnosis. So if you are finding something before it has symptoms, by definition, it's going to be smaller. And if you think about cancer, we know that there are 4 stages. And so when you screen, typically you're finding things stage 1. And if you can find them stage 1, that chance of survival is much higher. So we know for prostate cancer, survival is really, really great for stage 1 to 3. And by the time you get to stage 4, this is 5-year survival, that's when the survival falls off. And so if we can find these things before they're stage 4, we're going to be impacting survival. We know that screening decreases mortality. So this is a mortality of all, we've got lung, colorectal, prostate, breast. This is prostate, this blue one here. Since screening started, we've seen big drops in mortality for all cancers. And modeling shows that probably screening is responsible for anywhere between 40 to 70% of mortality reduction. There's treatment advances and other things, obviously, that are also contributing. You'll see in prostate here, we really level out, and we're going to get to this in a little bit. So this is, again, I keep going back to breast because this is where I've done a lot of my work, but there are so many parallels that I think it's applicable. So this, when we were doing our breast study, that one that I showed you at the beginning, I kept thinking, this is going to be so much less money if we find these cancers early, because I work on the oncology wards, I treat these patients, I know what it's like when you're using immunotherapy, targeted therapies, expensive, all these expensive drugs. So if you're finding something earlier, doesn't it save money? But all we could find in the literature in terms of costing was something that was from sort of 2008, 2009. And so this is a study that I did with a number of colleagues. The stages go this way. So blue is stage 1. This is stage 2, gray is stage 3, red is stage 4. These are subtypes of breast cancers along the way. So we don't really need to pay as much attention to that. But what we found when you look on a per case basis is a stage 1 breast cancer costs you about $30,000 to treat. A stage 3 costs $100,000 to $150,000, and a stage 4 is anywhere up to $500,000 or more. So the stage really impacts the cost. And so when we plugged this into a cost effectiveness analysis, what we found is that screening for breast cancer, it's not just cost effective, it was cost savings. It actually, you made money by screening because you were treating so many of these cancers at an earlier stage. So when I was putting this talk together, then I started thinking, okay, well, what's the prostate cancer equivalent? Do we have this data for prostate? And so I went looking. This was the most up-to-date study I could find. It's from 2010 to 2017. And these are men younger than 65. These are older than 65. This is early stage, advanced stage, and it's $60,000 there. And these are all the different kinds of treatment. So again, you can see, I mean, I don't have it as clearly as for breast, but the same holds true for prostate cancer, that you see those earlier stages are so much less money to treat. And when you think about PSA, a single PSA test is $40. So in the grand scheme of things, this was from, my husband was reading a paper this summer. This was in the Globe and Mail in July, I think, or April maybe. He's like, what is this drug? This is crazy. So this is Pluvicto. It's one of the PSMA radioligands. It is for metastatic prostate. You get 6 doses, and the cost of that is about $162,000. So those are the kinds of costs we're talking about when we're talking about treating advanced stage cancers. So we're going to focus in on PSA screening a little bit. So PSA is a protein made by prostate cancer cells. And when you have prostate cancer, you have more of those cells, making more PSA. So there you just have a little bit of PSA, there you got a lot. And so the level in your blood can tell you the activity of prostate cells. PSA is a really great test. Like if you look at a mammogram, it only looks at the breast. If you look at PSA, it's looking at your entire body. It's a really great test. We maybe just didn't do it properly when it was first introduced. And so it kind of got a bad rap. And so we're going to go back to that in a little bit. So what's the evidence behind PSA screening? How did we end up where we are today? The first, or one of the biggest randomized control trials was this. It's called the PLCO trial. And this trial was a big randomized control trial. They took people who got PSA screening and people who didn't, and then they compared what happened in terms of prostate cancer mortality. And at the end of this big, expensive, fancy trial, what they found was that there was no difference between the two arms. There was no benefit. And so that was one of the big tests, the big studies where we said, okay, well then why would we screen? But people who were involved in the trial and other scientists looked back afterwards because they said, this doesn't make any sense. And what had happened in that trial was 90% of the men in the control arm, so they were not supposed to be having any screening, had had PSA tests. Okay. So it was essentially a study of PSA test versus PSA test, which is why it didn't actually show an outcome. When you look at some of the other trials, the European randomized study was a PSA every 4 years, showed a 21% reduction in prostate cancer mortality. The Gutenberg trial showed a 44% reduction in mortality. And this is a big observational retrospective trial that showed a 64% reduction. And when you look at those numbers, and again, I keep thinking from my breast cancer lens, they're pretty much exactly the same as the benefit that we see with breast cancer screening. And so these numbers seem to be good enough for breast, but not good enough for prostate. The number there's a term we use called the number needed to screen. And so that's the number of men that you would need to screen to prevent one death. And so that is about 1,400 at 9 years. It's about 30. It's pretty much the same for breast. So they're very, very similar. So PSA screening has evolved. We've seen guidelines change over time. And this is what I was referring to in terms of temporal differences that allow us to kind of assess the impact of PSA. So we see that PSA first came to be in 1986. It was recognized as a way to follow men who had prostate cancer diagnosis. So a tool to kind of follow up after treatment. So that was the very first time it was approved. In 1991, that was the very first paper where someone said, hey, we could use this for screening as well, not just for following men with prostate cancer. And what we saw after that pretty quickly was this stands for the Canadian Task Force on Preventive Health. They came out right at the bat and said, don't screen. In 1992, the American Cancer Society said, we think we should screen. The US FDA approved PSA for screening in 1994. And so all throughout this time period, you see this arrow here, we see PSA screening rates going up, up, up. In 2008, the US, for the very first time, said, whoa, not so sure. We're going to say there's not really enough evidence for men younger than 75, and we definitely don't think you should screen older than 75. The task force again came out, in 2012, then the US said, you know what, actually, we shouldn't screen at all. So there was a very clear point in time where there was a recommendation against screening. In 2014, the task force came out again and said, the Canadian task force, and said, don't screen. And then in 2018, the US said, oh, wait a second, we're looking at all this data, and maybe we should be screened. And we're going to give a neutral recommendation for men 55 to 69, and we're going to say if you're over 70, we shouldn't screen. So what happened in 2018 that they said, okay, maybe we should screen again? What they found was that they were seeing more prostate cancer, they were seeing more aggressive prostate cancer, they were seeing increased stage 4 prostate cancer, they were seeing mortality stagnating, and mortality increases in Black men and those over age of 60. So these changes, they monitor quite closely in the US, or at least they used to. And they said, you know what, we need to revise our screening recommendations. So what about Canada? PSA, as you saw, screening has never been recommended in Canada, which in some ways makes this analysis really much easier because that's a variable we've taken out. We know in Canada we just never recommended it at all. But what we see is that because we live close to the US and we hear a lot about what goes on with them, what is happening in Canada is reflecting really what's happening in the US. There's variable access, so some provinces pay for PSA, some don't. Certainly Ontario is self-pay, BC is self-pay. But we do know that PSA screening is happening. So in the Canadian Health Survey, which Eric's team is involved with, they see that over 50% of men have had a PSA at some point in their life. But we also know that screening has dropped off in the recent years. So we've seen a 56% reduction in one Ontario region. So we know that those recommendations against screening are being reflected in what's happening with PSA uptake in Canada. Just a bit of backdrop on Canadian guidelines. Our Canadian guidelines are made by a body called the Canadian Task Force on Preventive Healthcare. And these guidelines are really important because they drive provincial practices. So the provinces look to these guidelines to say, should I have a program or not? The more important thing I often think, well, equally as important, is those guidelines are looked at by family physicians and primary care providers to provide counseling to patients when they come in. So if someone comes into my office and says, should I get a PSA? I look to these guidelines and say, oh, actually, they say you shouldn't, so no, I don't think you should. So this is because family physicians and primary care do not have the time to be researching all the evidence behind this. They look to this body to see what they should be doing. So in terms of what's been going on with guidelines, we've seen, I don't know if you've been seeing in the news, but there's been lots of activity around our guideline process. So in October of last year, they called for an external expert review to look at this task force because there was so much concern about some of the guidelines that were coming out, especially around breast. In the spring of this year, Minister Holland put a temporary pause on the Canadian task force. And at the time, they were working on the new prostate cancer guidelines, so that was frozen. In June, this report came out, and it said, we need to modernize, we need to make our guidelines more inclusive, more up-to-date, using more recent evidence. And so there's currently a process where by next spring, there should be a new task force kind of structure and body to put guidelines in. So this is all the backdrop for these things that we're seeing. So our prostate cancer guidelines, screening guidelines, have not been revisited since 2014, so over a decade ago. And when our task force is looking at evidence to make these guidelines, they really prioritize randomized controlled trials. So those ones I talked about where you have a control arm and a not control arm. And they include that one trial where there was found to be significant contamination and no benefit. And so because that's included, it kind of drops down the benefit of screening and has led to some of the recommendations against. This is a quote from one of the task force members. And it was in the Globe and Mail, just reading my Saturday morning paper. And it says, I can tell you a story from my own practice. I screened a man in his 60s and we found a cancer. He went on to have surgery and he developed incontinence and impotence. He probably didn't need the surgery in the first place, and he suffered these complications which really affected his quality of life. So this, I find, is kind of embodies the narrative that we hear about screening, that it's overdiagnosis, it's causing problems for something that didn't need to be. And so I think this is really sort of the mindset that we're hearing on a national level in terms of screening. But what we know, especially people who work in the field, is that things have really changed and science is changing all the time, and technology and techniques and drugs are really changing. And so using old trials, especially ones that maybe are contaminated, doesn't make a lot of sense when you're trying to decide what to do here and now. And I will say that this is from a patient that I'm looking after. This is his bone scan, his metastatic disease. So, you know, what we're seeing clinically right now is more and more cases of metastatic prostate cancer coming in through the door. So I think one of the most important things to know about prostate cancer screening is how it's changed. Because frankly, when we first started, we were probably doing it wrong. Right? When it first came out, there was an over-enthusiasm, there was an exuberance. Everybody got a PSA. If your PSA was over 4, you got treatment automatically. So there was probably overdiagnosis at the beginning. I don't think anybody is saying that there wasn't. So this is what it used to be, but it's a lot different now. So in 2025, you only would be offered PSA testing if your life expectancy was more than 10 years. So again, that deals with that overdiagnosis with people with lots of other medical issues. We look at longer screening intervals. You wouldn't do it every year. You would try and de-escalate some of those people who are lower risk. You would, as to your point, you would repeat that PSA. So if it's up initially, you're going to do it again because we find that decreases biopsy rates by 25%. You're going to get a risk assessment with an MRI. So if your PSA is repeatedly high, you're going to get an MRI, and that will say, you know, is there something that we need to biopsy? And if there is, where are we biopsying? So yeah, you're not just going to have a blind biopsy, you're going to have a biopsy that actually targets a concerning lesion. And there's new techniques evolving where instead of doing a biopsy through the rectum and you have increased rates of infections and complications, they're trying to do them through the skin instead. And maybe the biggest thing is the adoption of active surveillance. So like we talked about at the beginning, uncoupling that diagnosis and treatment. So you're not going to treat everybody you find. If that prostate cancer you find is a low-grade prostate cancer, a low-risk prostate cancer, you can follow that along and intervene only if necessary. So this is an example of the way we used to do prostate cancer biopsies, like a grid, and you just kind of put all kinds. They're kind of not very nice. You probably, maybe people don't know.
We've been there.
You've been there? I am sure they're not very nice. That's this picture made me think they're not.
Brings back numbers.
And this is now the approach. So you've had your MRI, there's a concerning lesion, you're going to target that lesion. So just, it makes you realize that we can't be judging screening based on the way it was in the 1990s. It's a very different kettle of fish now. And so, you know, we're recognizing that there are problems with overdiagnosis, potentially with PSA, but rather than just saying, oh, there's overdiagnosis, don't bother, there's overdiagnosis, but how do we address that? And how do we do it so that we don't have such an issue with that? This is the Canadian Urological Association's guidelines for screening, because they have always said that we should screen. So they really try and de-escalate screening. So if you have a PSA less than 1, you really only need it every 4 years. And if you're over 60 and you have a PSA of less than 1, then you probably don't need any more PSA testing because you're probably never going to get a prostate cancer. Whereas if your PSA is 1 to 3, you test every couple of years. And if you're higher, then you're more frequent testing. So, you know, you adjust the testing to what the PSA is. So this brings me to our study. That's just all the backdrop so you can appreciate what we've done. So what we did was look at Canadian prostate cancer outcomes relative to these guideline changes that you saw. We used 40 years of Canadian Cancer Registry. So our Canadian Cancer Registry is this amazing hub of data that has all of the cancer cases diagnosed in Canada, or most of them. You can all of them. There we go. And their stage. Well, for certain years, their stage. We know we can link it to death, so we can see who died, who didn't. And so we had over 500,000 over 500,000, prostate cancer cases. We had 148,000 prostate cancer deaths. We looked at two populations. We looked at 50 to 74 kind of as a whole, but we also broke it down into 5-year age intervals because you see very different patterns based on age. And when you just look at it in bulk, you miss a lot of the things that are happening. We looked at number of cases, mortality stage. We looked at net survival, which is cancer-specific survival. We didn't have PSA data. We didn't know if these cancers were screen detected or not. So this means this is not a study where we can say cause and effect. We can look at trends and infer from that. But that would be certainly the limitation of this study. And we had a multidisciplinary team. So we had Statistics Canada with Larry Allison, who's the survival guru. We had a number of clinicians, urologists, medical oncologists, radiation oncologists. So really the whole kind of perspective looking at this. So what did we find? And this study is going to be published hopefully shortly, ideally by the end of the month. So what you're getting is kind of hot off the press. People haven't seen this yet. So it's really fascinating how prostate cancer changed in Canada with the advent of screening. So this big blue line here, this is 1984. And you'll remember that PSA, the very first PSA, which was for following existing cases, was 1986. So this predates the existence of PSA. So this gives us kind of a baseline of what was prostate cancer like before there was any PSA. And what we see, these are age groups along here in cases. So we see that it's just a straight line. And without PSA, these would have been cases that presented clinically. So they would have presented because of bone pain or, you know, your urological symptoms. And you see that there were more and more cases as you got older. 1993 was kind of the peak of when we saw a lot of these cases. And then you'll notice that the curve totally changed, that straight line became kind of a plateau. It shifted earlier. So 2007 is right before we got the first guideline to say don't screen maybe. And so you see, when you look at, you'll see more cases earlier on, and then you see this plateau effect with decreasing cases as you age. So we can certainly see that, of course, we can't link this directly to PSA, but we see that in the presence of PSA, the existence of PSA, there's a shift going from lots of cases just presenting in older men to earlier diagnosis and less cases in older men. And mortality changed accordingly. So again, there's your blue line, there's your green line, and you see mortality just drop down with the years. And the biggest gaps, the biggest change is really sort of in these areas here. This is incidence, so the number of cases, and this is for all men 50 to 74. And so what I've got on here, this is when we had the first paper for PSA screening, this black line. This is when the FDA approved screening here. This is when we had the first change to say maybe don't screen. This is when we said don't screen, and this is when we said maybe we should screen. And these asterisks along the bottom are treatment advances, which I'm going to go into in a little bit. So we didn't have many treatment advances, but we've seen tons of advances since about 2010. So what you see is that after PSA, there was a big jump in the number of cases, right? It just climbed right up. And then when we say don't screen, we see those cases fall off. If you look at it this way, you could just say, well, maybe all those cases are overdiagnosed, right? Which is what I think a lot of our research looking at the impacts of this before. It said, well, you found all these cases when you're screening, and then you didn't find them anymore, so you were just finding cases that didn't matter. That's been the perspective. And you could say that when you look at this, but when you break it down into age group, you're really not saying that anymore. And so this is those same curves, but by 5-year age intervals. And so this is 50, so 50, 55 to 59. This is the early 60s, late 60s. This is early 70s. This is late 70s. And these are 80s. And so what we see here is that in men who are 75 and older, the peak number of prostate cancer cases was actually before any PSA screening started. And after PSA screening, they just all went down. And so if you're talking about overdiagnosed cases, or cases in just men who were older and didn't have any other medical issues, that's not what we're seeing here. We saw that these men continually dropped. What we did see was peaks in men in their 50s, in their 60s. The highest increase was in these age groups here. And so although you might say, okay, maybe from the overall picture, we were just finding all these cases, what we're actually doing is finding cases in younger men and then not seeing cases in older men. So to me, that suggests that overdiagnosis is less likely. This is same kind of graph, but this is mortality. And so again, this is 50 to 74, so the whole age group. And what we see, again, so you see mortality peaking and then dropping very rapidly as we have PSA screening. And then when we say don't screen, we see that mortality really flattening out. You do see this is where I think the treatments are important. So there were some key treatments that came in here that certainly contributed to that. So some of the LHRH agonists or the shots that you might get for hormone blocking. But here's where we really saw the bulk of the new treatments. So these are treatments that were really for metastatic disease mostly, like docetaxel, abiraterone, and enzalutamide. Maybe some of these are familiar to you. There are so many new treatments in this era, but we're not seeing a corresponding rapid decline in mortality. That mortality really flattens out despite all these new treatments. And so it makes you wonder, is this just because we're not finding these cases earlier with PSA? So here's what we see in terms of mortality change. We see in men 50 to 74, a 50% decrease between 1990 and 2010, and only a 9% decrease in mortality since 2010, despite all these new treatments. And in men 75 and older, again, we see this drop in mortality with a lesser drop in mortality in the recent ages. And these actually, they're relative mortality, so we say they're not absolute mortality, but when you look at the absolute numbers, they're huge numbers, so they make a really, this 20% or 50% is a really big number of deaths. So if you're going to break that mortality down by age, you see essentially in the older men, the mortality just dropped the entire time. In the younger men, you see this kind of peak and then flattening, this drop and then flattening out. And again, you see most of the mortality reduction before things flatten out. If you think back to overdiagnosis, overdiagnosis is a diagnosis of a cancer that would never impact someone's life. So if you die, that is not an overdiagnosed cancer. So anytime you're seeing a mortality effect, you know that you're not talking about overdiagnosis. This is perhaps one of the most disturbing for me findings. So this is the change in stage 4 prostate cancers. And this is data from, we only have stage data back to 2010, so it limits how we can kind of analyze, but this is 2010 to 2017. And what we see are the rates of stage 4 metastatic prostate cancer go up by about 50% in all ages over this time frame. So it's huge. The biggest increase was men 75 to 79, but you see this 50% really across all age groups. So huge increase in incurable prostate cancer after the point when we said we're not screening anymore. When you look at survival by stage, this is the encouraging part, has gone up. So survival for stage 1 to 3, we saw that at the beginning, it's about 100%. It's still, it can't really go much higher than that, obviously. But stage 4, here is where we see the impact of all of those different treatments, all those little asterisks. They really have made a difference. We see that basically we jump from about 50% to 57% survival for stage 4, and a slightly lesser increase for older men. So stage-specific survival has gone up, but overall survival has gone down. And so this is their survival by age groups. And it's complicated to sort of analyze this because survival may have been sort of artificially increased initially because you were having a lot of those stage 1 treated cancers. But certainly the decrease that we're seeing towards since we stopped screening is related to that increased number of stage 4 cancers. So because you have more stage 4 that have a lower survival in the mix, your overall survivor is going to drop. So this is what we found. And I think it tells us a lot about prostate cancer screening. I think we can use our national data to kind of audit and figure out what is the impact using those time changes. We can see that what is happening in Canada is reflecting what the guidelines are in the States, because those big curves, those big changes, there were never guidelines to screen or not screen in Canada. We always stayed the same. So the fact that it changed so much means we're really looking at what happens in the States. After screening became widespread, we saw that diagnosis shifted to earlier ages and that cases in men and older men just continually decreased. We saw that prostate cancer mortality decreased by about 50%, and the biggest changes in mortality were in men in their 50s and 60s. We saw that when we said don't screen anymore, that steep mortality kind of flattened out. And so I kind of in my brain, I think of it as, we're running to stand still. We've got all these new expensive, fancy treatments, but it's really just keeping us kind of steady because we're finding so many more of these late stage cancers. And we saw that the late stage cancers increased by about 50%. So despite multiple life-prolonging expensive therapies, our overall survival is dropped. So I think we now have to take this back and think about PSA in the context of all the things that I was talking about in the beginning. Should we to PSA or not? Without screening guidelines in Canada, PSA screening is happening. We can see that in these numbers. But PSA screening is happening in an opportunistic manner. It's ad hoc. You can get PSA screening if you're an educated person, you have a doctor you can go to, you can advocate for yourself, you can pay for the test, then you're going to get PSA screening. It means that screening is not happening. There's no guardrails on it. That's the way I think about opportunistic screening. It's screening without guardrails. So that 80-year-old could get a yearly PSA when really they shouldn't, because that's going to drive overdiagnosis. It means that we can't implement screening like we should with those dedicated de-escalated protocols where if your PSA is low, maybe you don't need screening, right? So if we're doing it anyway, we should be doing it in a way that makes sense and that minimizes the potential risks inherent or harms inherent in the test. And there's a lot of people that say we should just screen high risk. That's what some of the most recent articles have been saying. But when you see those number of cases, if we just screen high risk people, so people with a family history, we're going to miss out on a huge number of cases. So when I started this study, one of my colleagues said, oh, well, what do you think about PSA screening? Do you think you should screen? And I said, I thought about it and I said, I don't really know, actually. My mind was not made up because for years and years I've been following these guidelines and it was kind of indoctrinated in me like it just causes overdiagnosis. We shouldn't be doing it. But if you ask me now, I have a very different answer because looking at all this data, understanding the impacts, I do think we should be doing it. But I think we should be doing it. We shouldn't be thinking about PSA in the context of the early 1990s, where we talk about massive overdiagnosis and issues like that. We should be implementing it in a thoughtful, careful way where we're minimizing the problems that are potential with that test. We have to know that we've made huge strides in terms of overdiagnosis and overtreatment. And so we can't just think of it like we used to think of it. We have to acknowledge that the suffering, the difficulties, the pain, the cost of stage 4 and what that means. And I think we focus so much on overdiagnosis and we really don't focus on underdiagnosis. And so I think we need to be shifting the conversation actually to underdiagnosis. So I think it's time to stop just blanket saying, you shouldn't screen, it's overdiagnosis. I think we have to be a little bit more thoughtful because it obviously does have impacts and really significant impacts. Question? Yeah.
I recall reading something, but I don't have it with me. I've written down at home that they're pursuing other screening tools for prostate cancer. Do you know anything about that, or?
I mean, there's lots.
In addition to PSA.
Yeah, I mean, PSA is
the number one.
It's I don't think there's anything else that's hit prime time.
Okay.
I think there can always be advances and different things, but I don't think there's another replacement at the moment.
Okay.
I think what you might be referring to is starting to use MRI much more than just PSA.
Maybe that's what it was.
But typically you wouldn't use MRI without
not for routine.
Yeah. This was in lieu of PSA.
Well, there's all kinds of sort of theranostic. So the whole PSMA and the fact that we have, there's a leap into kind of imaging and diagnostics and therapy at the same time. There's big fields that are opening up that are.
Right.
Yeah.
Thank you. Excellent.
Can I ask that question? My name is Danny. Thank you very much for addressing this issue. I think this should be the #1 issue that all prostate cancer support groups in Canada should be addressing. And I'm the perfect example. In January this year, I was diagnosed with advanced prostate stage 4 cancer, metastasized full skeleton and including the skull. And, you know, I was a 7-day-a-week gym guy, 2 days a week ballroom dancer, incredibly fit, healthy. And under the current guidelines, my doctor would never recommend a PSA test for a very healthy person like me. And I hit the wall within 1 month and was essentially handed a death certificate. And I've already gone through chemo and I'm starting Pluvicto next week. I'm a really expensive patient. But I was never given a chance. And anytime I've had a PSA test, I had to ask my doctor. And he would always say, well, you know, you're in good health, you're in good health. But so this issue of not screening for prostate cancer is literally killing people like me that never had a chance in the first place. And so thank you very much for this. We really do need to rethink this in Canada. People should be given a chance to have caught it earlier and perhaps before it got metastasized. And I'm only 10 months into this, and it's accelerating really quickly. And so we do need prostate cancer screening, and thank you very much for doing this work.
You're welcome, and I'm really sorry that you're going through what you're going through. I think there's a degree of ageism, I think, sometimes too. I mean, the quality of life, if you're early 70s, you know, you potentially have a lot of years left of really good quality of life, and there's no reason that we shouldn't be, you know, trying to extend that for you or deal with that for you. Yeah.
Anna, you mentioned the guidelines, and I think you said in 2026 they should have the new infrastructure in place to start creating guidelines. Have you heard of anything when they might come out with new PSA? Or
I don't know. That's just to form the new guideline body. Then they will have to.
Okay.
Then they will have to start.
Okay. No, I just thought maybe through your nets you might have heard something. No. Okay.
No.
Thank you.
I've heard the whole or the overdiagnosis argument in a number of contexts, and the question that keeps coming to my mind is it that PSA is inaccurate? You know, like they can't tell what the PSA is telling them, or is it that, like, what's the breakdown between having the screening and getting those numbers and the diagnosis where it becomes overdiagnosis? Is it that we don't understand?
I think this is more a historic issue where I said, so back in the 1990s when you had that PSA, you had your diagnosis, you were treated right away. And so maybe you had sort of an indolent prostate cancer that wasn't going to do anything and you didn't need that treatment. And so that's why it's so important to understand the advances that we've seen, that, you know, if you uncouple that diagnosis and that treatment, you can wait and see if you actually do need to treat or not. You can also refine how you administer that test so that you don't pick up, say, you don't have a biopsy when you don't need a biopsy, or all of those things that we talked about. But it's that the same concept comes up in breast as well. But really overdiagnosis is more an issue in really much older individuals with lots of medical conditions. So we should not be screening men in their 80s, because really you need that 10-year sort of trajectory to say, okay, it's worthwhile treating. So
Because the prostate cancer may not be what ultimately kills them.
right.
I have a little comment, if I could make, just on my experience. I was diagnosed about 20 years ago, and I just want to comment on how that went with my GP. And he was educated in South Africa, so not North American experience. So probably about 25 or 30 years ago, he did digital rectal exam, and that went on for a few years, and then they decided to do PSA testing. And so about every 2 years, I paid it was $35 at the time, and so that went on for a bit. And then at one point he said, you know, this PSA, it keeps rising. I think we should go and see if we can have a look. So the first look was with ultrasound, just to see if there was something there. And the ultrasound analysis suggested that samples should be taken. So we did that, and then, well, it went on to the surgery. But the critical part, I think, was this GP of mine, he just used trend analysis. He didn't recommend surgery or testing as soon as it went up, 1 or 2 points. It was over a period of probably about 10 years. And I'm shocked, actually, that there aren't more doctors taking that approach instead of going by some rules or some guidelines or their recommendations for or recommendations against. Just use your brain and think about trends. And if you see a rising, if the trend is the PSA is rising, then use other methods to not treat, but to continue to explore. So, maybe there has to be some change in the education of GPs and others to think about trend analysis.
I think if we were using the Canadian Urological Association guidelines, there are 3 tracks, and if your PSA is higher, you're testing more frequently because that's what you're watching for. And there's things like PSA velocity and doubling time and free to total. There's ratios. There's different ways. You're right. There's more sort of subtle analyses you can do at that point. But I think what I see happens is the conversation doesn't even start. We don't even start to talk about testing because there's this blanket don't test. And so you never get to the point of the serial monitoring because you don't know what your starting point is. Yeah.
Well, my doctor sure did believe in testing. Even the DRE, digital rectal exam.
There's not a lot of evidence for DREs, and the reason being the prostate, you can only feel one side of it when you do a DRE because you're feeling from the rectum. But so you wouldn't feel anything in the middle, you wouldn't feel anything on the kind of the front of the prostate, you'd only feel something that happened to be on the back. So it's not really a great test. The PSA is a much better test than the DRE.
Yeah.
You keep wanting to ask.
How does the PSA testing post-surgery, has it got the same issues as pre-surgery? It's kind of odd. I've had a radical prostatectomy, and they're doing the PSA test, and it kind of doesn't make sense that the prostate's gone, but they can still test for the antigen and use it as an indicator.
It's a great test for tracking post for recurrence. But interestingly, so some men might have surgery, some might have radiation, right? There's different options. If your prostate is gone, so if you've had a surgery and removed that prostate, your PSA should be 0. It should be undetectable because you don't have a prostate to make.
Unless there have been some escaped prostate cancer cells.
Unless it's somewhere else, and that tells you there's a problem. Yeah. And so then you start. So that's why it's a really good tool to watch afterwards. For radiation, it's a little bit more complicated because that prostate is still there, so it's still making PSA. And you see post-radiation often like a kind of flare, like you see this bounce in PSA. It goes up, and then eventually about 3 years out, it'll kind of hit a nadir, and it should stay there. And there's a plus or minus that you want to stay within, and if it goes above that, that's when, again, you worry about, and it's called a biochemical recurrence, right? If the PSA is going up, and with surgery, it's really good to follow, because if you do see it going up, then you can do things like salvage radiation. There's things you can do to deal with it.
I did radiation, and they did tell me that there was this possibility of a bounce, and that didn't happen to me. So it doesn't happen to every person. In fact, I just had a urinary block a little while ago, and so they did another cystoscopy. And the urologist made the most amazing remark as he was having a look at it on the screen. He said, "Oh, look there. It's right in the prostate section of your urethra, and your prostate looks very healthy."
Way to go.
Do you know how much radiation that prostate
That's undergone.
But he said, no, it can happen that they end up looking fairly healthy tissue.
Yeah.
So
So if you're on 9 months of ADT after radiation, when would you expect the PSA to rise or the nadir to occur? You said 3 years with no ADT. ADT, I guess, delays that by?
Not necessarily, because the ADT isn't impacting the prostate. So like it's shutting down your testosterone. Right?
Yeah.
I mean, I did brachytherapy, high dose rate brachytherapy, followed by 15 sessions of external beam. And that was in the middle of 6 months of ADT, and I stopped it. That's 8 years ago. My PSA is still under 0.02.
Way to go.
That's a good thing.
Just wanted to remark how sophisticated the PSA testing numbers are. That when I was first I'd had my regular annual PSA test in April. Then I was having other issues with my back. They did another PSA test in January. It went up from the 3 to 52, and then they said, "Okay,
Wait a second.
we're going to get you in to see somebody."
Something here.
And every time I was going to see 2 different doctors, so I had 3 different PSA tests over 3 weeks, and I went from 52 to 72 to 92, and I thought, I'm going to be dead before I get into space. But that was 5 years ago.
And prostate cancers are quite different, right? There's low risk and there's intermediate risk and there's high risk, and one, the PSA trajectory isn't the same for everyone.
Right.
We are getting questions online in the chat.
There was one back there. Yeah.
So what I ask people online to do is if they do have a question, please use the raise hand feature there so that we can see that you want to make a comment or ask a question, and then we can get you to unmute and go ahead. So that clear for everybody online?
Can't hear you.
I think there's one behind you.
Yeah, I was just going to say, because you've done so much comparison to breast screening and breast cancer, why are they so insistent on a woman starting mammograms? Like, if there's no history of breast cancer in her family, she's got no issues, but they're so insistent on doing mammograms, but they're so reluctant to do PSA tests.
Honestly,
It's coming down.
Here it comes.
I think a lot of the changes that we've seen in breast screening have been due to patient advocacy. And I think, I don't mean to, I'm treading on narrow. Sometimes women might be a little bit, more proactive and more
Vocal.
vocal. I think there's just been more vocal kind of advocacy pushing for changes.
And you're not wrong. We know that.
Yeah.
I'm not that I'm sure.
No.
Get knocked down.
Men don't like to talk about it. It's interesting. We, in Winchester, they do a PSA clinic every September. And when you talk to the individuals going through that and you ask them how they heard about it, a good portion of it's because either their partner's with them or they heard it from their partner. So as men, we tend not to want to do anything about our health. and therefore it's.
So I feel like
the ladies that.
there's been a lot of push and advocacy that certainly the change to screening in the 40s, that was the result, I think, of a lot of advocacy and research, but concerted advocacy. And so I think it needs that kind of pressure from you guys.
Well, when I started this journey 12 years ago, Tom, I think, is online. He said, we're 30 years behind breast cancer. And I could see that when I started my journey, but I can see that gap narrowing.
Yeah.
Guys are starting to talk, well, look at this and look at that. I could stop my guys in my little town of Morrisburg. They know what I do. I've got a problem, can I talk to you? So I think we're getting there slowly, but.
And honestly, I think, you know, when you say erectile dysfunction, when you say urinary incontinence, you scare the bejesus out of, you know, and I think that's almost been used almost threateningly, or like in the context that it's sort of presented as, yeah, you could have this screening, but here you might end up with impotence or incontinence. And I think that really shuts down a lot of the conversation before it starts, honestly.
And maybe if I could mention something, in fairness, one of the papers that Anna did with colleagues in respect to breast cancer was directly cited by a number of the provinces, including Alberta and Ontario, as well as the U.S. College of Breast Surgeons provided an award recognizing it as most impactful article of the year of over 11,000 articles that have been published. So it was evidence, but then it was evidence that was backed up by advocacy from those that wanted to see action based on that evidence.
And that's why we did this study, because you need, I'm a data person and I'm an evidence person. And, you know, I think we need to look at, we have trials, but we also need to look at the real, what's happening on the ground, what is happening in Canada, and we need to have the numbers to support things. I don't think we should just be blindly saying, yeah, let's do this. That's why when I started out, I was like, I don't know if we should do this. But now, seeing those mortality drops, seeing the stage 4, I'm pretty convinced, quite honestly.
We did have a question online. Stephen Dix, are you there? He had his hand up and he wanted to speak.
He's unmuted.
Tom, you have a question or a comment?
Yeah, I don't know if I'm coming through, am I?
Yeah, you're coming through.
Okay, I'm in Winchester, and Doug already mentioned about the PSA event that we have here, and we've had over, the last 2 years, 500 people. And the idea is to prevent or to provide awareness and for people to get a baseline. And that was the thing that we really promote, is to get this baseline so that if there is future testing, and like we've had over, 500 people go through in the last 2 years, and 80 some have been diagnosed for follow-up. And we stress the follow-up does not mean prostate cancer. It means you need to have looked into. And so it's the education part that it's important. And unfortunately, like we're preaching to the choir here, but how do you get this information out to the general public? Al has already mentioned that when we had a wellness event here a week ago, and we end up spending more time talking to the women than to the men. And unfortunately, it's an older group. And my challenge is, how do we get to the younger generation? Because unless people get diagnosed by their doctor, if the doctor promotes a PSA event or a test, it doesn't ring. I'm perfectly healthy. There's nothing wrong with me until they get diagnosed, and then they start down this road. So information is important to get out to these people.
I think I agree, but I think if you have an organized, that's the difference between opportunistic screening and an organized program. So when you have an organized program, so I work with Cancer Care Ontario, I'm the regional lead, I do all the sort of quality assessment and education for family docs. You have a program where people get letters inviting them to screen. You're this age, now you got you probably had them for colon screening, right? Your letter comes in the mail, so you're like, okay, I have to do this. So if prostate was an organized screening program, people would get invitations, they would get reminders, you would have the screening done properly as opposed to this kind of ad hoc all over the place. So I think if you really want access, you have to do it that way. And the other part is with an organized program, you can typically self-refer, because right now, a lot of people don't even have family doctors. And so they don't have someone to go and talk to, even if their family doc did agree to order one.
Well, I think that's one of the challenges, hopefully, is that it gets things going, because since I've been diagnosed, I've a lot of men around me, so I'm talking in late 50s, early 60s, and tell them, have you had your PSA? And they go to their doctors, and the doctors don't know it's not necessary.
Because of that
stuff
stuff.
here. My father had surgery 20 years ago. I've been monitored, and then a PSA went up, and I've got a diagnosis. Like most of the people around me, their doctors say it's not necessary. Oh, you're healthy. It's not needed. If there's no family history,
So there needs to be a shift. There needs to be a shift in the way we think about it. But the reason the doctors say that is because they're told not to, because of these concerns around overdiagnosis.
So if you decide to be you're a doctor and you don't believe that those guidelines are right, you can still say you should have a test. So you're not contravening any kind of medical body where you could get some kind
Why
of
am I getting in trouble for standing here today?
No, that's the thing, because if that's a deterrent for doctors, then.
but that's what we have to pay for.
Well, that's the other part. The other part of organized screening is you don't then pay for the test, right? It's covered.
I remember the first time I asked my doctor, and she said, "Oh, well, it's expensive. You're going to have to pay for it, and you have no symptoms." And I'm just okay.
Well, and most people, doesn't matter men or if your doctor says, "Well, no, it's not really," you're gonna, of course, you're gonna say, "Okay, there."
I had a friend of mine that I finally talked him into getting his PSA last January, and he was diagnosed with metastasized prostate cancer. He died in April. He would have benefited from an earlier test. He was in his mid-60s.
And I guess part of the problem with overdiagnosis is you don't, you have to treat, you have to be careful and treat, but you don't really know who is going to be that.
Yeah.
I mean, we know a little bit because you can stratify on risk, like low risk, intermediate, high. But do you want to take the gamble that you're going to be that person? That's, most people would say no. Yeah.
The tendency now in all the readings that we're doing are that the decision to have a PSA test should be made on the basis of a discussion between yourself and your doctor.
Yeah.
The thing I think that's hampering most men is they aren't aware of the risk factors that the doctor is. So when they go into a conversation with that and they say, "Well, I'm a black man and I'm 42 years old. Should I be tested?" Do men understand? I don't think men understand what the risk factors are in terms of age, ethnicity, and also whether or not it's in your family.
Yeah.
And so part of our work here is to educate people in that respect, and just get people aware of what the risk factors are,
and PSA,
so that they can have that intelligent discussion.
And PSA testing is covered if you have a family history. So if you have a first-degree relative with prostate cancer, you do not have to pay for your PSA test.
But most men don't know that.
I know.
I didn't know that either.
I didn't even know that either. I mean, my son.
A lot of doctors don't know. A lot of doctors.
And guess what else? A lot of men don't know if it's in their family.
No.
Yeah.
Well, also there's, you didn't talk about it, or you didn't know what it was, or
your father could have died with it rather than dying from it.
Yeah.
So it's in your family, it's in your history, but it just wasn't the thing that your father or grandfather died from it.
And I think that's where breast cancer advocates have done really well, is they do a lot of education and a lot of, talk about risks and breast density, all the different things, and are really quite active in trying to, which I think it's.
Hal is thanking you for a very educated presentation.
I'll make just one more comment. This same PSA test that they did at Winchester, we did a survey, and so we talked to 200 of the 251 men, and we asked them 6 questions. But one question that sort of surprised us said, "Do you have a family doctor?" And 95% of the people that attended did have a family doctor. So next year we're going to have a follow-on. Well, have you ever asked the doctor for a PSA test, and did he or she say no? So because we keep hearing that doctors will say no, but we have no stats on it, so next year at least. The other question we asked is, do you have prostate cancer in your family? And about 33% of them had no idea if there was any prostate cancer in their family. So, but as I say, every woman over 30 knows someone who's had breast cancer, you know, so we just don't share the information.
Guys just have to talk more.
Speaking of that, any suggestions on how to where we should be focusing our advocacy to the medical community to sort of try and bring us up on par with the breast cancer?
I think breast advocacy has gone the political route more than the medical route.
Okay.
I think for the medical route to change, those guidelines have to change, quite honestly.
Okay.
I talked to MPs at Queen Park and they just, it goes on deaf ears.
So you
Yeah,
need,
yeah.
because you need data to back you up. So I'm gonna give you this data.
That's all right.
You take it and run.
Okay.
Just so you know, both the Canadian Cancer Society and Prostate Cancer Foundation have co-signed a letter that went to the provincial government in the last month supporting PSA testing, saying get on it. So at least at the political level, they're trying to do, at our level, we can't do anything. It's got to be at that level.
And it's difficult because we're provincial.
Yeah.
You have to advocate in each province.
Oh, yeah.
And so I know the breast cancer world, they're very organized and they have kind of lead advocates in each province that are working, speaking with health ministers, trying to kind of, because cancer screening programs are provincial programs. Even though you have a federal guideline, you kind of have provincial implementation.
I have a comment about the business of reviewing these guidelines and then getting on with rebuilding them. And that process, as you've shown us, has been a rocky road. It's been on it again, off again. I did read an article, I think it was an article based on the Canadian Neurological Association's position on this. As you said, they've always advocated regular screening. But are they being excluded from the effort to come up with new guidelines?
Don't even get me started with the guts. The task force, they intentionally exclude experts because they feel that experts are biased and have a conflict of interest. And so experts have not been allowed to vote on guidelines. This is one of the things that created the pause because there was outroar around the guidelines that were coming out. And so although I think they would probably be happy to be sitting on that, they've not been included as far as I know. I don't know if they had a.
But does this make sense?
No.
Seems backwards. Seems backwards.
No.
So, I mean, it seems to be
So I think
the advocacy here should be focused on the government to tell them you can't exclude experts from the people who are trying to devise these guidelines.
So that is why there was a pause. That is part of the reason why there was a pause. And that is why the task force structure is being kind of worked. So hopefully one of the things will be including experts, but there will still be issues, I think, around, it's complicated.
Yeah.
It's very complicated.
Okay,
Sad.
We have to stop.
we're gonna stop. Okay, thank you very much. And I apologize, but she's got a life unlike the rest of us. Thank you very much. This has been tremendous.
Yeah.
PSA is such a hot topic, especially amongst the people that are attending this, because we really believe in it. But sometimes we seem to be talking in a vacuum. So it's just tremendous that you've done this study and that it's going to be published. And then at least we can start as our organization pointing to it and help with the advocacy. So thank you very much.
You're welcome.